Focus on actually health delivery and infrastructure. We know the way I have looked at the literature and what the community has done, or health community, that there are three components of health infrastructure, resilient health infrastructure. One is institution and organization. So the institution and organization can do the regulatory framework. They can develop a robust health information system to respond. Like one example is CDC or Robert Koch University in Germany. The second is the knowledge. Knowledge, not only knowledge of the professional, but also public to respond to the health services offered by the health community. And so that's very, very important. And third is physical infrastructure, which is, we know that the building, the commodities, the medicine, and other equipment and logistics. So we are glad to have three experts, and all three of them actually have the expertise on those elements what I have just presented. So I want to introduce, the first I would like to introduce, I think I'll start from the right, health service to the, not only the public, but also how to train health professionals. That's very, very important. My second person to the right is Eduardo Jejeski, and the name of his organization is very interesting, INSTEAD. So INSTEAD stands for Innovative Support to Emergencies, Disease, and Disaster. And Eduardo is the CEO of that company, and he's very passionate about bringing the technology and design to overcome pressing challenges. He has a lot of experience in Asia, particularly in Cambodia, and we will know about how to do the large-scale enterprising in terms of computing, introducing, and practices. And the last distinguished, actually the panelist, I think she doesn't need an introduction, one of my peer and mentor, Dr. Kausar Afsana, who is the Director of Health, Nutrition, and Population BRAC, but she's also the professor at James P. Ganter School of Public Health. And Dr. Afsana's actually the career is currently opposite to mine. I started as a programmer at BRAC and then became the researcher. And Dr. Afsana started as a researcher and then came to the program. Actually, I do think that that's very important because she has been able to bridge her research skill to the implementation, which is very, very important as now we talk about the evidence-based intervention or program. So I would like to start with the first question to Dr. Afsana, because when you think about the resilience or the disaster, Bangladesh is also kind of not only the victim of the natural disaster or the Ebola epidemic, but also man-made disaster. If you think about Rana Plaza or the fire in garments, even recently there is a gas pipe actually leakage in one of the the posh residential area in Bangladesh. So my question is that we know that when you look at the population, the most vulnerable population is actually children and women. So in terms of resilient health service delivery in Bangladesh, what are the weak links to overcome, and what can we do to overcome those weak links if we want to give a better quality services in case of those resilient or shock? Or I know that you are not very comfortable with this shock and disaster, but generally, yes. Thank you.
Thank you, Malavika, and good afternoon, everyone, and welcome to this session. I hope that I don't see the number is very less now because of the topic, probably not much interested in health.
The finance.
Okay. So, but we know that from the beginning, and I was in the morning in one of the inaugural session of Bangladesh Demographic Health Survey. And we know that Bangladesh is a country, we have many, many good stories and success stories and really doing well. But on the other hand, this country is in such a positioning in a way that, what is that called? The climate itself is a part of our life, and climate is affecting our life. On the other hand, we know that as the citizen or the person of this country, that how resilient we are. So one is the system, one, and also the people. And as Malavika is mentioning some of the things, and I was just thinking for a few days, because we have been working in the area of resilience, and we use the word resilience constantly, but sometimes we always think that resilience is the climate change, but thanks to Malavika that she brought some of the issues we really need to think about. And this is quite critical, and I'm representing BRAC here, so I need to also, not only I would like to talk from as a Bangladeshi, but I would like to give some of the lessons that what BRAC is doing in this country. So let's, in the natural disaster, I mean, the country is in a situation, of course, we talk about women and children, and when we bring health, we always forget about nutrition. So health and nutrition are not separated. And we know that the country is quite successful in reducing the number of fertility, but our population is increasing, and you can see the push and pull factors working. And so what urbanization means, and I can see that in Bangladesh, when people always think, oh, people are coming to urban areas, but I always say that Bangladesh probably is, the whole country is an urban country, because look at it, wherever you go 20 years back, because I started back in 24 years ago with Malavika, we had talked together almost 1 and 2 months before I joined BRAC. So 24 years ago, when we started and we saw Bangladesh, and Bangladesh is really becoming an urban area. And on the other hand, the issues coming in terms of climate and in terms of also the man-made disaster. So what is the role of the country and state, and also people and as a big stakeholder in Bangladesh, the BRAC. So think about in the climate areas, so what we have been doing. Over the years, we have seen that, this is a country where, floods are coming and cyclones are happening. But on the other hand, we always forget that some of the floods we completely ignore, because people are always used to this kind of flood. It's called slow flooding. And if you go to monsoon time to the villages, you'll see that, some of the lands water is coming slowly. At some point, water will be also going down. People just move. So the resilience, what do we mean by resilience? You can see that people do know that how to adapt their life and living with all those situations. That means resilience. But how this country is responding? We have seen over the years that, some of the cyclones happened in this country, disastrous. 1970, then 1992, and again, 2007. The difference you can see that what happened at the time and what happened afterward. And now that, we know definitely that we are better than many developed countries in the world, how to address all those issues, especially in terms of immediate response. So people already know that what people should do, and at the same time, the state and the civil society, the way they work together when a disaster happens. So this has, in fact, almost like a cultural norms and practices within the country. When anything happens, the government immediately start calling, and NGOs are already prepared. And in Bangladesh, we have more than 44,000 volunteers working. I don't know whether we do know. Even answers, they're all ready to support in any disaster happens. So think about when Cedar and Ayla happens, and I was in the field. It's very interesting. When Ayla happened few years back, I was in the field and I didn't even know that Ayla is happening, because I know the weather is bad and it's, there is also storm. But in the city, I was in Khulna, and I found that, I slept at night, and in the morning I wanted to meet the mayor of the city, and then I heard the mayor left, and then I said, where did he go? And everybody was saying, didn't you know that what happened last night? I said, no. It's Ayla. And then, I went to all those places, Ayla affected areas, and I found that how people live there. I didn't have any idea before that that, because I have been working in slums in Dhaka city for years, and I can see that the slums already is built up in all those climate affected areas. And people's living situation is much worse than the people's slums, urban slums, where people are actually living. So we forget about all those people who are suffering from the salinity of water, who are suffering from arsenicosis and other problems, many problems. And salinity of water is not only our diseases. We always think that people will be suffering from hypertension or many other diseases, but we are not thinking that how it is affecting the agriculture production. And even arsenicosis, we thought that, okay, people are suffering in these particular areas from arsenicosis, so that's their problem. No, because the vegetables produced there is coming here, fish is coming, many other things are coming, where the whole country, even globally, we are affected. And we need to find out, not only from the health perspective, we think about the global issues, that how the water system is affected by the other countries. Are we thinking about that? We have been discussing over the years with India. India is talking to China. The China is affecting India, India is affecting Bangladesh, and then, many other countries. So, but we are just talking. We are not seeing the way we should work together. And we discussed in Paris, and that some of the countries, in fact, couldn't do very well. Bangladesh is one of them. And we thought that there are many indicators that why Bangladesh was not successful. But we know that people are affecting. And 160 million countries people, how could you expect that those people will not be pulled out or pushed out of the country? So this is quite important. And the healthcare system, I think the way it should respond immediately, we can manage just after the flood, just after any cyclone, but not the way it is happening slowly, affecting our lives. The example I brought from, as Malavika mentioned about women and children, one of the districts in North Bengal, South Bengal, what happened that we know that the research is showing that the preeclampsia rate is quite high there because during pregnancy, the hypertension is happening. And in fact, interestingly, it was my Nana Baris, my mother's village. So I have seen when I was really young that in each and every houses they have filters, water filters. But when we started our program, in fact, I wanted to see the water filters in their house. I couldn't find anywhere the indigenous water filters in any of the houses. Then I was looking for, okay, if they don't have that filters, probably they might have other kind of filters because, we are modern, so we are buying things from the market. But there are no filters in any of the houses. So where are those indigenous knowledge? And where are the modern systems? So both systems fail to address the issues of salinity of water, which is affecting women's health. And forget about the health system. The people who are sitting in I shouldn't say, but they're not at all thinking about all those not simplistic issues, but the issues which is really affecting mother's life and then, of course, the children's life. So I think I should stop here, but Malavika, if you give me time, I'll speak afterward.
Thank you. One of the another major component of resilient health service delivery is robust health information system. Yep. And I know that you are working how to use the technology, because if we need quick response, we need a very good surveillance, we need a very good information, not only for service delivery, the supply chain, the health worker. So
I want to tackle that. Thank you, and thank you, Dr. Afsana. From the perspective of somebody who builds the technology, we see your teams as the superheroes, right? And we're the ones who give them the tools and the gadgets that will help them do the best things. And sometimes it's not about the tools and the gadgets. It's really about the philosophy with which you design the program. One of them is really to encourage the unexpected. And this is, for example, from the work we've been doing with disease surveillance in Southeast Asia. There's a lot of systems that do disease surveillance. People report how many people are sick on a certain week with this disease, with that disease, and it all goes into a database. We decided to take a different approach and have local health workers in village areas be in SMS chat rooms with each other and with like managers of the district. So we created like a pyramid of chat rooms that spanned the countries, and this was Cambodia and Thailand. And they were able to report the diseases, 3 cases of dengue this week, 10 cases of malaria, and that went into a database. But they were also in this chat room. They would remind each other, oh, remember the boss is coming, and like we need to be at the clinic. And they were just helping each other with little bits of content, asking questions. And what happened when Storm Ketsana came through and started a tropical storm of significant strength, health workers were the only ones that were interconnected in these circles at a local level. And the chat became a way for them to say, oh, this is what's happening here, what's happening over there, this village is flooding, we don't have boats, can somebody come and get some boats so we can get the families out of these houses? And they became the impromptu disaster response network just because they were the ones in touch with each other. Right? And like, so designing for the unexpected, allowing people not just to submit formal forms, but allowing them to write on the margins, metaphorically speaking, of the technology is important because it allows them to invent uses on their own of how to use the tech. Other examples of that is very simple things that empower local groups to do better and react and improve. We've been helping Tanzania, Rwanda, Ethiopia, and other countries come up with something very simple, a live list of your health facilities, what services they provide, what's their infrastructure, how well is infrastructure working. It's like, do you have tuberculosis services here? Do you have emergency maternal child health? Are your fridges working? Which cell phone companies have good signal? And this seems like a very simple data set, and the challenge is governance. How do you keep it live and updated? And by just having that simple data set somewhere where people trust the quality of the data, starts a golden cycle of use where local companies start saying, ooh, I'm going to do a system where people can SMS what's the nearest facility that does X, and I can send them the answer. Research can say, let's look at what are the underserved areas based on like road networks where we need to start building the next facility. And again, it's a list of facilities. It's not like massive innovation. It's not molecular research that will solve AIDS. But if you can solve those simple problems, it gives a platform for everybody else. Another one of the principles is really empowering the edge. I think in crisis, we tend to think of the responders and the response effort. 99% of the response is done by the families and neighbors. So if you see them as an effective tool that eclipses what all external agents can do, what can you do to amplify their effectiveness? After the Haiti earthquake, we did a program where we were helping the UN clusters send geo-targeted SMSs to different places of Port-au-Prince saying, this hospital here is closed. Do not walk with your kid. Pediatric services are provided over there. Water is going to be distributed in the afternoon. HIV medications are available at this clinic. And basically sending them the information to help them help themselves better. There was a conjunctivitis outbreak in the camps. And it's like an invisible threat. You're like, after an earthquake, you're outside of your house. You're not going to find that out. But health experts could find that. And by sending information to people, wash your hands, don't rub your eyes. If you see kids rubbing their eyes, ask them this and that. They were able to overcome a lot of things much more effectively than just left to their own devices. But you're trusting them with their agency as a partner in response and giving them what they don't need and allowing them to tell you what you don't know about the situation. Same thing can be done with like FM radio stations, where an FM radio station is one-way broadcast, but if now you have a phone line where people can leave recorded questions, right? They can ask questions for the next program, and it creates a loop. They can leave recordings that will be played on the next program. And for example, Farm Radio Africa does that over voice messaging a lot to help local farmers share that local knowledge. It's like, where do those native filters go? Where do the native knowledge of the plant species combinations at work go? And sometimes a matter of finding it and helping amplify it, and technology can help. And I think the last principle in crises and health is avoid the red phone. And the red phone is a metaphor of the thing you only use in a crisis. Like the president has to pick up the red phone in times of war to call somebody. And the thing is that, when something happens, is like where's the red phone? And it's old and it's unplugged, it's dusty. Like, how did you use this? What was the phone number? Like, it's very different. You just pick up your mobile phone, right? Because it's what you use every day. So designing for the everyday, we think, is key. I think a failure of that we experienced was during the H1N1 outbreak in Mexico, where there were really proven interventions to help modulate population behavior by sending these SMSs and so on, that could have been sent to help reduce the speed of contagion in the country. And just because there was no a priori contract with the telecommunications companies, with the Ministry of Health, we couldn't enable that program and we couldn't activate it. And there's nothing so frustrating as knowing you have a proven intervention with proven results, and for the lack of a contract done the week before, right, you could not deploy it. But you never know which week is the week before, so you might as well do it any day, right, and just have it on the ready. In the space of the Ebola response, there was a great example of how something designed for every day, not for the critical disease outbreak, helped with everyday health. We were working with diagnostics manufacturers. The people became critical because these devices sending out information allowed the rapid validation of the assays. The Ebola assays were not tested because there was never a market for Ebola diagnostics. So when the moment where people decided, okay, we better invest in this, having live feedback from the devices in Liberia and Sierra Leone allowed the diagnostics company to tune their algorithms and identify, in the PCR systems, the pathogens early, accelerating the validation. So again, it's encourage the unexpected, empower the edge, and design for every day in ICT, I think, helps the health system to be more resilient.
Thank you. So Dr. Afsana talked about that for emergency response, we are actually doing good, pretty good. The problem with for the slow disaster, that whether our health system is ready for that. I had already talked about the technology that we can use, but most important foundation or pillar for any health service delivery is the human resource. And we know that, Jay, that the organization name indicates the medic mobile. So it's the frontline health workers who can be trained using technology, mobile. So what will be their role, or how can they actually contribute in the resilience?
Yeah, absolutely. Thank you very much. And I was going to add another point to you. You made three pillars kind of your resilient infrastructure. I was going to add a fourth, and that's health workforce. To that piece as well. If I may, if I can be, yes, I don't know if I'm allowed to, but I would definitely put in health workforce there. I'm going to start actually on Medic Mobile. You can look up our what we do around the world on medicmobile.org. I won't bore you with the details of where we operate, but I'm going to use our experience specifically in Nepal during the earthquake response to draw some examples out of where we made some mistakes, definitely, and also where there are those weak links, as Dr. Afsana said, in the health system that could possibly be improved. After the earthquake occurred in Nepal, there were thousands and thousands and thousands of people who descended upon the country, all with different motivations. I would say, calling it a circus is a pleasant term. There's other more unpleasant terms that were used in the public health community in Nepal to refer to this arrival of thousands and thousands of people and also outside organizations that came in. However, in the midst of all of that, we were asked by WHO along with the Ministry of Health to implement an outbreak surveillance system. As Eduardo has already mentioned, surveillance is not that big a thing. We already had a national level system functioning in Nepal in all 715 reporting units. So leveraging this same band of users to report on disease outbreak in affected districts wasn't such a large stretch. We were leveraging really what was already there. To get to some of the challenges and why one challenge that's very particular to Nepal is, and I'll use this sheet of paper to illustrate it. So this is a normal country with roads and nice, maybe some are paved, maybe some are dirt, but you can kind of get around from point A to point B reasonably. This is Nepal. Everywhere you go, you're traveling over a mountain or a hill to get there. There are communities that you can't get to by boat, you can't get to by helicopter, you have to hike there for 2 weeks. So whatever hardware you deploy whatever training you deploy, it has to be resilient. It has to stand up to 3 hours a day of electricity. That's pretty much it. If they break it, somebody in the community has to be able to replace it. That normally doesn't bode well for smartphones and tablets and all these high-end devices that those of us in M-Health and E-Health get starry-eyed and look at like shiny objects in the distance. It has to be something that works for a week. It has to be something that works off of a GSM tower. It has to be something that the user can communicate 8 or 9 fields of data within a structured SMS. That's Nepal. There might be other countries where, you know, a smartphone was great or a tablet's great. For the context of Nepal and other countries with similar topography, it's really, really tough to scale. I would say in terms of, you know, in terms of challenges that we faced as we deployed, and these are related to those communication and institutional communication problems within our health systems, is that we had constant form changes that took place. This was because every week there were new staff that were arriving from abroad, both to help out the Ministry of Health and also WHO side. And so you had form changes that happened all the time. We actually reached a point where we had to act kind of like Switzerland, but without the money, to negotiate between the two parties and say, hey, this is your form, this is what you're going to use because this will achieve your health outcomes. The second one that we didn't anticipate was user behavior. So we had 715 users plus nationwide who were reliable reporters. And we thought these guys were going to go ahead and be great reporters as well for outbreak surveillance. That was wrong. The earthquake impacts lots of people in different ways, and we had reporters who were absolutely 100% reliable become unreliable. We had big fish text. That means like you would have someone sending in 200 cases of fever with jaundice, for example. Why? Because they just wanted someone to show up with aid. And so it really changes, and in particular an earthquake. I mean, the interesting thing about a disaster like an earthquake is, unlike a cyclone or unlike a hurricane, you don't know when it's going to begin, and you don't know when it's going to end. And you don't know when the next one's coming. There's no meteorological service to say, this cyclone is coming on this day, it'll hit these cities, and it'll last for this long. And so that creates even more stress among your health workforce. And I would say the biggest number one kind of challenge with regards to resilience of the health system throughout this whole crisis is the health system itself, and this is many, many countries, it is not focused on the continuum of care. It's still focused on verticals. Someone might receive outstanding treatment for tuberculosis. But the unfortunate fact of the matter is when that person develops diabetes, their pathway to care deteriorates. And that's a problem in many, many countries. And if that exists in your health system, and I don't care how great and resilient your TB program is to after an earthquake or after a cyclone or after a typhoon, if we're not providing that continuum of care to the patient, that's not a resilient health system. Sorry. We have a lot of work to do in our groups, I think among our e-health community and M-Health community, groups like Instead, Medic, Vodo is also here. We have a lot of work to do to educate our clients about this, because we're one of those rare organizations that gets to work across all of those verticals and that sees them and that sees the redundancy in the systems that are created. And in some cases, I think it's our obligation to educate those. We talked about this part of the break. We need to educate those organizations of that they're in fact implementing a redundant system that might not work. We definitely have that responsibility to help build resilient health systems on our side. Yeah.
Thank you, Jay, because I think in Bangladesh there are more problems because it's not only the disaster but also it's suffering from triple burden of diseases, the acute infectious, non-communicable disease, road traffic accident, then you have all this man-made disaster.